Hello, my name is Jacob Avila of Core Ultrasound.
And I'm Mike Macias from the POCUS Atlas.
What's up, dude?
What's going on, man? It's good to see you.
Thanks. I'm happy that you're able to hang out in my house. I have this little recording studio I'm trying to figure out. We got a camera here, we got one there, one there. It might be too much, but we're gonna see. Got a new light. What do you think?
An impressive setup, man. I'm really impressed, and I'm looking forward to recording more sessions here.
Oh yeah,
awesome.
yeah. It'll be
cool.
good.
Yeah.
We are gonna do our second session for our image review, and this is reviewing images that we do at the hospital where we work, Temecula Valley Hospital. There's a residency there, so we have a lot of ultrasound clips come through, and we do image review and feedback for the residents, and we figured we'd share it with you all here because it's just such good pathology that we're seeing. You good with that?
Yeah, I'm
all right.
good with that, man. Let's do this.
First one. Mike, what do you think of this one?
Not good. Is my first impressions here.
Yeah.
But what I'm seeing is, looks like I'm seeing tendon.
Yeah.
When I'm looking at this image, the first thing that pops out to me is discontinuity of this structure. And I'll just point it out.
Mm-hmm.
On the left here is this fibrillar appearing structure that appears to be from here to here.
Mm-hmm.
And then over here, I'm seeing another piece of it. And it looks like right in the middle, we just have this disruption. And I see what looks like fluid moving back and forth. And what I'd be worried about here is a complete tendon rupture.
Yeah.
Given the size of this tendon, I'm going to go with Achilles.
Yeah, good job, dude. It's totally an Achilles. And do you always need the ultrasound for an Achilles rupture? Because if the calf muscle is not attached to the calcaneus, do we need to use this to confirm it? Is it necessary?
I don't think you always need it. I guess you could call it a little bit of a point of care ultrasound party trick in a full rupture.
Mm-hmm.
I think the helpfulness in that full rupture is one, the patients really like to see what's going on and understand it.
Yep.
So when I'm doing it, I'm telling them what's going on.
Mm-hmm.
They can really see what's going on. But I find it more useful in those partial tears. If you have a high suspicion, you have a negative Thompson's, they're still moving it, but it's swollen. You really want to look at that tendon and really estimate, is there a partial tear? Is it 50%? Is it 10%? Is it just a strain and there's just a little fluid around the tendon? I feel like that really helps me with my management of these patients.
I agree. Right here, one more thing is this separation to me is it helps me out. What I'm doing is almost I'm doing a foot flexion kind of maneuver, and you can see it kind of separate out there a lot more. And if you're not 100% sure of what you're seeing is a full tear or not, I think that although it is a little bit painful, if you just do it a little bit and you see this right there, you see how kind of this, I was pointing at it, this distal part is definitely stretching while this proximal part is not moving at all. That's pretty much a complete rupture.
And I think the concept, it just demonstrates the concept of dynamic imaging in ultrasound.
Right.
And that's why I love point of care ultrasound for these purposes. We can just do motions on the patient, evaluate really, is the functional structures moving appropriately? Is there a dynamic issue?
Yeah, I agree. This is something that I'm doing a lot more of at New Job at Temecula Valley Hospital. This right here, this is a fracture. You can see here that this is a cortex right here. We have a good step off and then another cortex down here. This is the tendon up here. This is a distal radius fracture with dorsal angulation. Now, I don't think that you should necessarily be doing this to primarily diagnose a fracture. I think you definitely need an x-ray, at least at the beginning. Where this is becoming so much more useful for me is in the middle of the reductions, right? So what I did here is did a hematoma block on this patient, and there's not any C-arm, right? So I don't have a way of seeing how the alignment is in the middle of my reduction, and so the ultrasound actually becomes hugely beneficial here. I think a little better, right?
Yeah, that's awesome, man. Almost.
I gave it one more crank, and then we put it right about here. It's pretty good. Actually, followed up with this patient. They went to Radies, and they did an x-ray. They didn't have to do anything else. The bone just was healing good on its own. So it worked out pretty well. What's the youngest person you've done an interscaling block on, by the way? Because typically with these distal radiuses, I like to do brachial plexus blocks. But the kid was kind of on the young side, right? And so I wasn't sure at what place would the patient be chill enough to let me stab them in the neck. What is your thought? What's the youngest you've done a block on?
That would be tough. I probably would be thinking about like a teenager I'd probably block.
Yeah.
I probably wouldn't go younger than that.
Mm-hmm.
The thing is for this distal
Yeah.
radius, I find those hematoma blocks are so useful.
Yeah.
And I find that if you get a good block,
Mm-hmm.
especially using ultrasound, you can get right in that fracture fragment.
Yeah.
They are
pretty well.
tolerating their reduction
Yeah.
so well. But I really think, and I'm really glad we're talking about this image because this is really the modern C-arm.
Right.
I feel like
That's
every
true.
ED doc or advanced practice provider or anyone providing care to our ED patients, you really should have this in your tool belt because it's just so nice when you're at the bedside to just watch that fracture fragment move into place.
Agreed.
And just for everyone on, all our viewers, if you want to just show me, where are you actually placing that on?
Yeah,
I'm just
yeah,
gonna show
so
you
here.
my hand.
So what I'm doing now, this is actually important. I'm putting the transducer here to start with, but I'm rotating it a lot. Like here, I'm going medial. I'm actually going to go on this polymer surface as well, because especially if it's like a small fracture fragment, I might place it on one spot. I don't see it there, and so you need to move all the way around. You basically need to evaluate the entire cortex along the area where that patient is swelling.
Cool.
Yeah. Yeah, no worries. Sweet. Let's move on to the next one. Speaking of brachial plexus blocks, so let me tell you the story about this person. This was a dislocation of the shoulder. Now, traditionally with the dislocation of the shoulders, like you can talk about the supraclavicular versus the interscaling block, right? I mean, there's a brief discussion we can have about like the phrenic nerve. Like, what are your thoughts about like the chance that we probably block the phrenic nerve every single time we do interscaling?
I mean, I think it's a theoretical possibility.
Yeah.
I haven't really clinically experienced it much.
Yeah.
Usually I'm evaluating the patient and making sure they're
course.
going to be able to tolerate potential phrenic nerve palsy on one
Right.
side. But I mean, it's a possibility. And so generally I'm starting to reach more for the supraclav, and that's a whole nother topic we can have.
Yeah.
But I still love the interscaling, and
too.
I find it effective. And as long as I feel like I'm comfortable with the fact that they could lose that phrenic nerve temporarily, I'm still going for it.
Yeah, I mean, I'm basically the same. If I'm doing interscaling, almost invariably what I'm doing is I'm using just plain lidocaine. Okay. So it's like the faster acting one that we have. Because really I'm doing this most of the time just to reduce the shoulder. So I only need it on for like maybe 30 minutes total. Yeah. And I should be done. I think that just thinking about where the phrenic nerve comes off, I really feel like we're probably at least partially affecting that phrenic nerve. Like I'm assuming every single time. So what that means to me is that means that if a patient's oxygen dependent or they have like a pneumo on the other side, I am definitely not doing anything interscaling. I'm steering clear of that because of the potential possibility. I'm not aware of any complications that have ever happened for this, but it's a theoretical risk. And it's interesting because the supraclavicular block actually it works pretty well from my literature review. And you've been doing those a little bit more, right?
I've been doing a lot of supraclaviculars.
What's your experience been with shoulders and supraclavs?
Honestly, I'm pretty much mostly shifting over to supraclavs just because I feel like I can see my needle for a lot longer, and I like using the first rib as a backboard, so I feel pretty comfortable with that as a landmark. I like seeing the artery and then the rib right underneath, and I know that I'm just going to be targeting just lateral to that, and I'm really able to watch the spread. Sometimes I have difficulty finding those three chords in the interscaling, so that's why I've made a shift. I still do both for my practice, but I think I'm favoring the supraclav a little bit more for proximal shoulder injuries, fracture, just like.
Yeah, I think I'm gonna start doing it more. Now this is a interscaling that we tried for a shoulder, and we tried it in plane, but the problem is that it was an elderly patient, not a whole lot of muscular tone, and we use these amazing blunt tip needles for nerve blocks. I love using them here. They're the ones that aren't sharp, and then the anesthetic comes out kind of on the top. Yeah. What's it called? Is that TUI?
TUI.
It's a TUI. We have a TUI needle, and I like those. The problem is that when they don't have a whole lot of muscle tone, when it's hard to, like, the muscles don't stay firm when you're going through them. And so, like, all the anatomy shifts so much. And on top of that, with this patient, there was also a bunch of blood vessels behind where we wanted to go. So it wasn't amenable really to interscaling the traditional means. So what I did is we went out of plane for this one. So this right here is the brachial plexus. And you can see my needle right here. I'm doing the same kind of technique that I do with ultrasound guided vascular access. And you can see that there's my needle tip. I don't have like the best visualization of it, but you can see the brachial plexus is over here in this area. It's this kind of like wider stuff over here. And I finally felt like I popped through, and then I started injecting. You can see here I'm not quite in the groove because it went all the way up here. And there's my needle tip. And then we'll do a little bit deeper, do a little squirt. You can see I'm getting closer. I'm getting closer. And then right about here, I'll fast forward just a little bit. I really start to get kind of into that interscaling groove area, where right there, which is really where you want to be. And after like you squirt, we got that squirt in there, you can actually see the roots a lot better.
Yep.
There at the bottom. Right here. So these are like the roots here that we were trying to see that we couldn't see. And in these kind of elderly patients, they tend to not actually have big nerves, right? Because I think that the nerves get big with muscles. And if somebody doesn't have a whole lot of muscles, the nerves don't need to be big, so they just get small.
Yeah, trippy. That makes sense.
Yeah. Yep.
Yeah, that's impressive, man. I never done interscaling out of plane, but I feel like this was a really good use case when you really couldn't get good anatomy and follow the needle from a in-plane approach. So awesome.
Thanks.
Did you get good anesthesia?
I did actually. She had like no pain with the reduction whatsoever. Like slid in like one of the things with like nerve blocks is that, especially with this one, it knocks out motor as well. So it makes the reduction so easy, which is why I like it so much, to be honest. But superclav would work too.
Awesome.
So this right here is a supraclavicular block. Speaking of which, Mike, you want to walk me through the anatomy here before we talk about the block?
Yeah. So what I'm seeing here is the first thing that sticks out to me on a supraclav block is the axillary artery. So I always like to find that first. And so I can see that guy right here. This hyperechoic structure here is the first rib. And then this would be medial. This would be lateral. So we would expect that plexus to sort of be surrounding the axillary artery and lying just lateral. So we can see a bunch of little pieces of the brachial plexus. It looks like there's a couple areas of the plexus up here as well. So typically when I like to do this block, I'm coming in from the lateral aspect and trying to just bathe all of this plexus in. So I'm seeing the needle come down and sort of infiltrate this area. And I do see some fluid tracking around these roots of the brachial plexus here. Ideally, what I'd like to see is fluid surrounding the plexus down here, but I don't think it means that you're not going to get a block if you're injecting anterior to this and having the anesthesia spread. But what I really like to see is I want to get into this area and really bathe all of this nerve sheath.
Yeah.
What are your thoughts on it?
Yeah, the same. I think this block would work. I mean, if you're using lidocaine, it should eventually kind of diffuse through the entire brachial plexus. I often will do this after I've injected down here, right on top. They call it like the corner pocket, I don't know, whatever, pool reference. But I try to inject here first and get this like spread on the more kind of posterior lateral aspect of it. And then if I'm impatient, I want the block to work faster, I'll back up, then redirect it and get the more anterior one. But this might take a little bit longer to reach peak onset of anesthesia, but it should, or analgesia, but it should eventually get there as well. Yeah. So this works, although the traditional means is to get it down here in this area.
And then I really like on this image that you can see the whole needle. I think
for the
supraclavicular, you really have to know always where your needle tip is, because remember that lung pleura does lie deep to that first rib and lateral. So just always knowing where the needle tip is really important.
Yeah, I agree. All right, so this is something that I'm actually like pretty invested in, and that's cardiac arrest ultrasound, using it in arrest. There's some literature that says it delays pulse checks, but briefly, it's not the ultrasound doing it. The ultrasound only does what you tell it to do. And so if your ultrasound is delaying pulse checks, it's not the ultrasound, it's you are delaying pulse checks. Just like, don't delay the pulse checks. That's the first thing. Now, the way that I kind of try to not do that, not delay the pulse checks, is I actually will start recording. I put the loop up to at least 30 seconds. I'll start the recording, put the gel on like 10 seconds before, charge a defibrillator, put the gel on, have the towel in my hand. And as soon as it's pulse check, I basically go for the subxiphoid view, because that's the one in arrest that typically is like the easiest for me to get. Shove that in there and go up, like almost like trying to lift up the patient through their xiphoid. Like that's how hard I'm pushing to get the view as fast as possible. And there is actually some evidence or some literature out there that suggests that you just do your recording and then wipe the gel off and then look at it afterwards. Because like the getting the image and the interpretation of the image can be done in two separate times. And that might actually, lower the chance that you're going to prolong the pulse check.
Totally. Yeah. I Totally agree with that.
Yeah.
My two things are I love nominating someone to time the pulse check, count down from 10, whatever it's going to be, whether that's a nurse, a tech at the bedside. Someone needs to be responsible for that, right? So I have them count out loud. I want them to call me out if I'm on there too long. And I love what you're saying about getting in that subcostal space and being and recording. What I do is I'll actually just put it in that space even while CPR is ongoing.
Yeah.
Because then I can sort of see where my heart's going to be. Am I going to get that window? And as soon as they come off that chest, that image appears. So I think you got to have a strategy that you're going to use to minimize time off the chest. I think these are some nice tips just to really make sure you get that view. And then I agree also, take it once you get your recording, take it off the chest, look at your images after while CPR is reinitiated.
Yeah.
Don't waste time taking a look at it, trying to figure out what's going on.
Yeah.
While everyone in the room is just staring at you,
right,
waiting to get back on the chest.
Yeah, totally agree with that. Now, what if I told you, this is like the ultrasound that you get during the pulse check. What if I told you this patient had severe back pain and then collapsed? Like, what would you be thinking?
Aortic dissection.
Yeah.
I'm scared.
Yeah, me too. And then there's this guy over here, right? There's a bit of a pleural effusion, or excuse me, a pericardial effusion out here. So, I mean, it really fits with the clinical story. And then what do we do with these bubbles? What do these bubbles mean? Are these like little clots or something? Like, what is this stuff? Right there?
What we're seeing there is like probably like just agitated or rapid resuscitation with saline. So that's typically what you'll see if you have maybe a bag of fluid on a pump, or if you're agitating and giving something really quickly. You're going to see those bubbles. It's just agitated fluid going into the RV, and we can see it's moving. So we have cardiac activity here. If I'm seeing this, right, this is a person that I may be able to intervene on.
Right, of course.
Depending on what's going on. I'm seeing organized cardiac activity. Here's our LV, our aortic outflow. The RV has fluid moving through. And then, like you said, that pericardial fusion, we could see lateral to the wall. So you're right. If I had a tearing chest pain, sudden cardiac arrest with an effusion, I'd definitely be concerned about an aortic dissection into the pericardium.
There's one other thing too. Like, you see how the septum is kind of pushed down into the LV? This is probably due to some RV enlargement, to be honest. But this patient at this point had been down for probably 30 to 40 minutes. So it probably was just back up into the right heart, not necessarily like from a massive PE. Although, to be honest, it could have been a massive PE. I just think with the pericardial effusion, the back pain, much more likely to have been a dissection.
Yeah, for sure.
Yeah. And here's another one I recorded before I got, before pulse check, put it on there. Now, if you see this, do you need to wait 10 seconds?
No.
There's nothing,
back on
right?
The chest.
There's nothing. Like, if the heart happens to beat like 6 seconds later, that's still like a bradycardic arrest, and you still need to do chest compression. So if you get a good view, you see no motion whatsoever, don't wait for the 10 seconds, right?
This is really where pulse checks with ultrasound help. I mean, this is like, why are we sitting, waiting, feeling the pulse for 10 seconds?
We don't need to.
You do that in 1 second, there's no activity, you're back on the chest, right? There's no need to wait and sit and see if, do I feel something, do I not, right?
Yeah.
There's clearly no cardiac activity on that image. Back on the chest, CPR, good quality, right? And then repeat the next pulse check in 2 minutes. So I love using point of care ultrasound in arrest just for that reason.
Yeah, I mean, if you use it right, it's going to do the opposite of prolonged pulse checks. It's going to like shorten them. Should we what should we do here? Let's say this patient's been down for an hour.
If this patient had been down for an hour, what we're seeing here is no cardiac activity. You guys can see this is RA, RV, LA, LV, and we're really just seeing fluid moving from high pressure to low pressure, right? There's no organized activity, no movement. I mean, if you're talking about an hour of downtime with this, based on the data we have, this is pretty, poor outcome case, very low likelihood of survival, right?
I agree.
We do know based on the data that no cardiac activity on initial ultrasound portends a pretty poor prognosis. They're walking out of the hospital alive, and probably less than 1% for all comers. But if I had this after an hour of CPR, I'm definitely worried that it's even less than 1% for this patient. So it can help me. I might, I might not do another 20, 30 minutes of CPR after seeing this.
Right.
Especially in a busy emergency department, and we have to deal with resources for other cases, So I would definitely be kind of talking with my team about, if this is a good time to maybe stop resuscitation. It seems unlikely. Futile.
Yep. This is like my favorite thing to see. I love seeing this so much. What do we got here?
So I am seeing these hyperechoic area here that's
I
kind of
love that so
moving
much.
back and forth.
I
Yeah,
love
that
it.
is really, really cool. That is
Yeah.
the ultrasound equivalent to X-ray of air bronchograms.
Hmm.
But these are dynamic. And going back to, we talked about dynamic on that Achilles, is
Hmm.
that's what I love about ultrasound is we can look at dynamic processes because we're taking clips, right? We're
Right.
looking at things over time.
Right.
And so what we're seeing here is this is a lung, right? And
Hmm.
I always tell people, right, remember that ultrasound of the lung is not real, right? It's all artifact. But this is the first time we
Hmm.
actually see lung
Yeah.
tissue. So when you're seeing lung tissue, right, there's pathology there.
Hmm.
So we're seeing consolidated lung,
Hmm.
this hyperechoic bubbles moving back and forth or dynamic air bronchograms. And then there's a big effusion around
Hmm.
the whole lung. So I'd be worried about pneumonia and an empyema in this
Yep.
case.
Yeah, I agree. That so I don't think we 100% know exactly what's causing these dynamic air bronchograms, but I think it's basically like air mixed with fluid, so pus just in the airways, just like moving back and forth as this patient's trying to ventilate that lung,
Exactly.
which I think makes sense. But yeah, sweet. I think we'll stop there, dude.
Yeah.
Yeah.
Cool, man.
You do you want to do this again in a few weeks?
Yeah. Let's do it.
All right. Should we talk about our conference?
Yeah, let's talk about the
Let's
conference.
let's
Yeah,
talk about Sound and Surf.
Sound and Surf, man. It's coming up.
I'm super excited about it. It's the first in-person conference I've done in like almost 3 years now. It's going to be in San Diego, November 11th through the 13th this year. So it's coming up pretty soon. It's going to be at Stone Brewery.
Stonebury.
And you get to hang out with us and a bunch of other world-renowned, not us, but other world-renowned ultrasound educators in a pretty sweet town, our new hometown of San Diego in California. So the URL is soundandsurf.com. Hope to see you all there.
Thanks, guys. Look forward to having you there.